Okay, let's talk a little bit about Bruton X-linked agammaglobulinemia. How does this differ from severe combined immunodeficiency? The point here is, normally when we're talking about SCID, we said that there's probably going to be involvement of T cells, and in certain variants we can also have involvement of B cells. But the difference between the two diseases here is that with Bruton's we're just talking about B cell involvement. So our cell-mediated immunity should actually be functional in these patients. The issue here is primarily going to be with B cells. And if I don't have B cells, we're going to have major issues with our immunoglobulins. Okay, so B cells are going to be very, very low, and that's because this step, this BTK gene, allows for our B cells to essentially get out there into the circulation. So if I don't have this gene working, my B cells are not going to be able to get into the blood and eventually into the lymphoid tissue. And so my B cells, essentially, if I had some bone marrow here, right, so here's my bone marrow, my B cells are going to just be kind of sitting here in the bone marrow as pre-B cells. Okay, they're never going to make it out into the bloodstream, right? If here's my bloodstream, and then eventually maybe I have some lymph node, right, that these blood vessels are eventually going to kind of go into, right? I'm never going to be able to get these B cells out into the blood because I don't have this functional BTK gene. And so all of these pre-B cells are basically going to stay here, and in the blood, I'm not really going to have any B cells. And if I don't have any B cells, right, I'm going to have a hard time making IgM. I'm going to have a really hard time making any other immunoglobulins in general because I can't class switch, right? I'm not going to have B cells to bind to T cells to get activated to become antibody factories or plasma cells. Okay, so if I did flow cytometry on these patients, I'd see very low levels of CD19, 20, and 21. So what would that look like, right? So if I did flow cytometry on one of these patients, for example, right, and let's just say that this was CD21 and this was CD3, I might have, some level of CD3 that is normal, right? I might see a lot of dots representing CD3. And maybe I don't have any, dots at CD21, for example. And there's a lot of different ways they can show you this. But the point being, Bruton X-linked agammaglobulinemia would be in my differential. And again, if you go back to the name, remember we said that combined and SCID kind of makes me think of B and T cells combined, right? But when I'm thinking of this name, right, I'm looking at agammaglobulinemia. It pretty much tells you what's going on. A meaning without immunoglobulins in the blood, right? I don't have immunoglobulins, and why don't I have them? Because I can't get these pre-B cells into the bloodstream. Okay, and so that's why, again, if you know your CD markers, you can see a flow cytometry question, and you can say, look, I know there's no CD19, I know there's no CD20 or CD21, I know that my B cell levels are very low, but in some way, the T cells will be functional, right? They can show you CD3 on here, they can show you a lymph node and show you that the paracortex is completely normal, but there's, follicle atrophy, for example. Again, just putting all the pieces together with T cells and B cells like we talked about, you can distinguish these two different diseases with that information. And again, we just talked about this, all isotypes should be affected in Bruton's X-linked agammaglobulinemia. I also want to talk about common variable immunodeficiency because it often gets confused with Bruton's X-linked agammaglobulinemia because they're similar in that they both affect B cells, but they affect the B cells differently. Now, for most of these different pathologies, the presentation, it's going to be tough to just use the presentation to just say, okay, I'm at this disease or this disease. Usually, you're going to have to know a little bit about the diagnostics, the CD markers, the flow cytometry, what's affected, right? The pathophys. That's going to get you a lot of the answers on step one. But when you're talking about Bruton's and common variable immunodeficiency, the presentation actually can be relevant in that with common variable immunodeficiency, it tends to be less severe. And so these patients will typically present a little bit later in life. Usually post-puberty. The classic age range for questions is like between 20 years old and 40 years old. So if you have a patient that has recurring infections at 20 to 40 years old, and then they start giving you some clues that there's potentially very low immunoglobulins, right? You might be saying, well, could this be Bruton's? Well, probably not, right? Bruton's is going to be no B cells. And so these patients, as soon as they lose mom's IgG, they're going to start to present with symptoms. Whereas with common variable immunodeficiency, these patients will tend to present much later in life with low immunoglobulins and plasma cells. Okay, and the pathophys here is also a little bit different. With Bruton's, we were basically saying, look, we can't get any of those B cells out of the bone marrow, right? So we effectively have no B cells. The difference here is that in common variable immunodeficiency, we actually have B cells. We have normal levels of B cells. So on flow cytometry, we wouldn't expect to have no CD19 or 20 or 21 markers. We would see them. However, the issue is that we have B cells, but they don't work correctly. So the issue here is that we do have B cells here in the bloodstream, right? These are my B cells. So I have B cells, okay? I have B cells, but the issue is that they don't work. My B cells don't work correctly. So they can't produce the antibodies. They can't turn into plasma cells in these patients. Okay, so that's the big difference between these two. One of them, we have no B cells. One, we do have B cells. They just don't work correctly. One of the things to kind of remember here, medium low yield, is that common variable immunodeficiency is sometimes associated with increased risk of certain lymphomas, autoimmune disease, rheumatoid arthritis. And again, the same concept when we talked about the lymph node is going to be true here. Because we have B cells, but they're not functioning correctly, we're not going to see germinal centers. We're not going to see follicles that are going to be very active in general in these patients. We would expect to have very small follicles or absent follicles in a lymph node. But again, the paracortex should be untouched because paracortex is referring primarily to our T cells. And we'll talk about thymic aplasia here. I won't go into, all of the details here. I think it's just important to distinguish these. So let's just talk about how thymic aplasia is different from some of the other pathologies here. Now, with thymic aplasia, we're primarily going to be talking not so much about the B cells, but the T cells in particular. And the reason we're talking about T cells is because the T cells are going to be maturing in the thymus, right? We talked about that. Now, the issue here, again, you can see by the name, thymic aplasia, right? We're not really going to have a thymus. So if I don't have a thymus, I'm going to have a problem generating mature T cells, right? Because this is where pre-T cells, right, we're going to go. Remember that whole physiology we talked about, the whole mechanism of negative selection, positive selection, all occurring in the thymus from the pre-T cells. So if I don't have a thymus, we're going to have some major issues with making functional T cells. Okay, and why does this happen? Why don't I have a thymus? The issue is that we're going to have defective third and fourth pharyngeal pouch development. So this goes back to some of the embryology that we've talked about before. Third and fourth pharyngeal pouch are going to be very much involved with thymus development as well as the development of the parathyroid gland. And remember, the parathyroid gland is primarily responsible for calcium and phosphate regulation, okay? And we'll talk about this in more detail in the endocrine section. Again, I don't want to get kind of too off track. But the point here is, if I have a patient that has very low T cells, but completely normal B cells, I might be going straight to thymic aplasia here. Now, you might be saying, well, okay, well, in SCID, though, you can have very low T cells. And again, that's true. But the difference in thymic aplasia is they're going to kind of go on a little bit about this issue with the parathyroid. Because remember, this pharyngeal pouch development is not only for the thymus, but also for the parathyroid. So if you have a patient that has hypocalcemia in the setting of extremely low T cell numbers, now you might really be pushed in the direction of thymic aplasia. And the way that some people remember this is catch 22. Okay, so 22 is referring to the chromosome deletion that's involved. Okay, so this is the deletion that causes this issue with the pharyngeal pouches. So that's chromosome 22. And then each one of these is a very specific kind of category of pathology. So the C, you can think of this as cardiac defects, specifically conotruncal defects. And we talked all about this in the cardiology videos when we talked about tetralogy of Fallot. We talked about truncus arteriosus, and those two are very classic. So if you have a patient that has tetralogy of Fallot, really low T cells, hypocalcemia, very classic for this thymic aplasia. The A stands for abnormal facies. And there's actually a variant of this. That's the velocardiofacial syndrome. And then the T, we've already talked about, that's going to be the thymic hypoplasia. The C is cleft palate. And the H here is going to be the hypocalcemia. And again, some of these questions, you have to integrate a couple concepts, but your radar should go up. We have two diseases now that we've talked about with T cell deficiencies. And they're quite different, right, between SCID and thymic aplasia. There's some very classic findings we would expect to see with thymic aplasia. And remember, they're not always just going to tell you the patient has hypocalcemia. Maybe they'll say they tapped the patient's cheek and, they saw some twitching, for example, or, they're testing for Trousseau sign using a manual blood pressure cuff, whatever it is. There's going to be some clue that tells you that, this patient potentially has this electrolyte disturbance, but they might not come out and say it for a lot of these different things. So you have to be prepared for that as well. All right. And again, for the diagnostics, low T cells, like we talked about, this is going to be pretty similar to what we talked about with SCID. The difference is we're going to have some defect in the parathyroid hormone, the calcium, also some of the classic findings we talked about. There could be a heart murmur, abnormal facies, cleft palate, all would be more classic for thymic aplasia. And the other point is, if in SCID, you might see the B cells might also be very low, right? You might have absent CD19, 20, 21 on flow cytometry with absent CD3. That would be very classic for SCID. Not classic for thymic aplasia. The B cells should be working in thymic aplasia, which helps differentiate it from Bruton's common variable immunodeficiency, as well as some of the forms of SCID.